Okay, so we have now completed the first part of the talk, which was on adrenal physiology and the insufficiency disorders. And now we're going to spend our time talking about disorders of glucocorticoid excess, called Cushing's syndrome, and then sort of a very heterogeneous group of diseases which have a very variable picture, depending on where the enzyme deficit is, but there's disorders that are all labeled congenital adrenal hyperplasia. You'll learn about the most common one today. I'll talk about a couple more on Wednesday, and then you'll get it again in reproductive endocrine physiology. Just a word, I look out amongst you all, and I'm seeing sighs and other signals that there is sort of a high level of stress in the room. And that's not cool. You don't have to be that way, okay? This is supposed to be fun. This is fun, right? We do this together, you and I. I will bring you through this journey. I promise you I will get you to the other side. And we have to do it and have a lot of fun doing it, because this is one of the more elaborate, some would say beautiful, pathophysiology systems that you will encounter this year. In my personal opinion, it's the most elaborate. So just take a deep breath. Come up and ask me questions. Email me questions if you have it. Just relax. We're going to get through this together, okay? That's what I told my 5-year-old who went to kindergarten for the first time this morning, and my 9-year-old who went to 4th grade for the first time this morning. It's okay. We're going to get through it together. Don't be stressed. Don't be stressed. And they all said, "But Dad, you're talking about congenital adrenal hyperplasia today, and I'm worried about the medical students. They may not get it." They'll get it. They'll get it. They'll get it. Don't worry. Okay. So we are going to spend an inordinate amount of time this morning talking about glucocorticoid excess. Okay? This is a tricky one after that introduction. It is a little tricky. I will guide you through it. But then we're going to talk about a series of disorders that have to do with enzyme deficiencies, most notably this one here, 21-hydroxylase. And on Wednesday, I'll teach you about 11-beta-hydroxylase and 17-alpha-hydroxylase. They're a little confusing, okay? You do not have to, every one of these enzymes has a disease associated with it. I'm not asking you to know those or memorize any of these steps, although this was actually on my step 1 exam. And that made me be like, oh, I better be an endocrinologist now. If I wasn't thinking about it before, I'm going to think about it now. So let's talk about adrenal cortical excess. Here, aldosterone excess is called hyperaldosteronism. It presents as salt retention with hypertension and potassium wasting with hypokalemia. Okay? And the critical thing you'll need to try and differentiate, is this from an adenoma or bilateral adrenal hyperplasia? And then there are some funny things that look like aldosterone excess but are not. That's for Wednesday. This is what we're going to talk about today, Cushing's syndrome, okay? Hypercortisolism. It has a myriad of symptoms. The critical question is this an ACTH-dependent or ACTH-independent form of this syndrome? Okay? And by the way, just like adrenal insufficiency, the overwhelming most common cause of Cushing's syndrome is actually exogenous glucocorticoid administration. And then there's hyperandrogenism. We're not going to talk about that so much in the setting of tumors. When you have a tumor of the adrenal that makes androgens, that's very bad. It's usually associated with adrenal cortical carcinoma, which is a very nasty malignancy. These are large tumors that have usually spread by the time you find them. In males, making excess adrenal androgens has really no phenotype. In females, there's virilization syndromes that you can see. We're going to talk about hyperandrogenism in the context of congenital adrenal hyperplasia, which has to do with all 3 layers, not just a tumor of the reticularis or overproduction there. So what is Cushing's syndrome? It is a group of diseases, okay, and I'll show you the differential that makes up that group, whose common theme is excess glucocorticoid exposure. So if you think about what glucocorticoids do, it'll help guide you towards what the pathophysiology or what the phenotype presentation may be. There's excess central adiposity with peripheral lipolysis. So what does that mean? So that means that the peripheral fat stores break down, thin extremities, and everything gets sent centrally, a protuberant abdomen. We used to use words like moon faces and buffalo hump. No, not my day. I didn't use those words, but those are out there, but don't use them. Don't tell somebody, oh, buffalo hump. Excess catabolism, so muscle breakdown, right? Remember, you break down muscle for its nitrogen backbone and also to send precursors to the liver for hepatic glucose production. Osteoblast apoptosis and increased bone turnover, so patients with Cushing syndrome have osteoporosis. There's increased hepatic glucose production and decreased insulin sensitivity, aka type 2 diabetes. Weakened collagen fibers in the dermis, so there's violaceous striae and easy bruising and thinning of the skin. Some forms of this disease, when they're ACTH dependent, co-secrete adrenal androgens, and that would induce hirsutism or virilization in a female. Excessive amounts of glucocorticoids actually suppress the GnRH pulse generator, so there's amenorrhea associated with it. Because of the immune suppression, high doses of glucocorticoids, there's infections. Usually they're fungal skin infections or oral skin infections. And then if glucocorticoid levels get so high they overwhelm that enzyme, it can be a form of apparent mineralocorticoid excess, and that would induce hypertension with proton wasting and potassium wasting. And then for reasons we don't know, high doses of glucocorticoids can induce mood and depression. So these are very nonspecific things, right? Hypertension, diabetes, osteoporosis, these are common things. But when you see it in a younger person, together, it should raise your index of suspicion. There is a, quote, classic phenotype, and I'll show you a picture of the presentation of Cushing's, but Cushing's is pretty subtle and doesn't always present that way. The hallmark things, though, menstrual irregularity, hirsutism in a female, muscle weakness, plethoric face, which is sort of the moon faces. Easy bruising is a big one. Hypertension, reddish-purple striae from the collagen breakdown. These things that have a sort of higher discrimination index, when you see them together, it should raise your index of suspicion. It's not diabetes and hypertension so much, but in someone with diabetes and hypertension who has violaceous red striae over their abdomen, an early form of osteoporosis, they have easy bruising and bleeding or depression, that may be somebody you want to think about Cushing's in. So here is the sort of rounded plethoric face. It's very hard to see, but in this female, there's coarse terminal black hairs on the chin. That's a form of virilization called hirsutism. Here is excess fat deposit centrally. Relatively thin extremities for the level of adiposity centrally. These are your red, purplish, violaceous striae. Easy bruising. You can see a lot of bruising here. There's edema. This is probably a wound that is not healing so well. Anything else on there that you want to point out? Say it again. What? Yep, central obesity, good. Anything else? Edema, good. Not that they're short. Can't see how tall they are. But they're holding on to something, right? Patients with Cushing's have a myopathy, usually of the large muscle groups that are being broken down, okay? So what are the causes? Well, the overwhelming cause of a Cushingoid phenotype is right here. Iatrogenic pharmacologic doses of steroids. There are things that look like Cushing's. Alcoholism, depression, obesity. They have some or all of these clinical features of Cushing's, and actually when you test them, they actually have high levels of cortisol at times that they shouldn't. But if these are treated, okay, good luck with treating this one, or any of these actually, these are hard, but if these are treated successfully, then the features go away and the cortisol excess goes away too when you test. And that's called pseudo-Cushing's. So whenever you're testing for Cushing's, you have to worry about alcoholism, obesity, and depression. because they can mimic a Cushing phenotype and cortisol excess at times where there shouldn't be. The number one overwhelming majority of endogenous cortisol excess is an ACTH-dependent pituitary tumor. And that is specifically called Cushing's disease. The others are not called Cushing's disease. Ectopic ACTH syndrome is a form of ACTH-dependent Cushing's, but it's not coming from the anterior pituitary. And then an adrenal adenoma, or hopefully not, a carcinoma, is an ACTH-independent form. And I'll show you how you differentiate dependent and independent forms. The ACTH-independent forms, there's a couple of other. These things are extraordinarily rare. All of them make up less than 1% of Cushing. So the three big ones to know, once you've ruled out iatrogenic use and pseudo-Cushing's, are Cushing's disease, ectopic ACTH syndrome, and an adrenal adenoma. Do you remember this? Good. Okay, so how does this look? I can't, sorry. Can't sit still. This is a form of ACTH-dependent pituitary Cushing's. So how will that look? Well, let's make a small pituitary adenoma here, okay? And let us make it autonomously secrete some ACTH. Well, what's going to happen? Well, down in the fasciculata and reticulosa, but really focus here on the fasciculata, you're going to get a rise in cortisol. So you have an ACTH-dependent process from an anterior pituitary tumor that is secreting ACTH, driving up the production of cortisol. And we call this Cushing disease, aka ACTH-dependent pituitary Cushing's. Now, just so you know, because this is going to be important, remember we're dealing with syndromes of hormone excess. We're going to try and suppress this in some form or another. Now, because this tumor resides in the anterior pituitary, it actually still has some physiologic responsiveness. So if you raised CRH levels, you get more ACTH. And if you turned off CRH levels to 0, you might be able to drive down ACTH production a little bit. And this is known as suppressibility. It's suppressible, but not as suppressible as, say, a normal pituitary. Okay? Everything is right-shifted. The second form of ACTH-dependent Cushing's is from an ectopic, non-pituitary-based tumor. And there's lots of tumors that can do this. The most common is small cell lung cancer or bronchial carcinoid. So I've depicted here in the lungs a tumor. And that tumor is going to secrete ACTH. It shouldn't be, but it does. That ACTH is then going to drive forward in the adrenal the production of cortisol. Incidentally, that cortisol is going to go back to the anterior pituitary hypothalamus and suppress endogenous ACTH. Now, if there was a way to differentiate between endogenous ACTH and this endogenous ACTH that's coming from an aberrant tumor, that would be great, but there is no way to do that. So we're going to have to rely on something else. This is known as the ectopic ACTH syndrome. Ectopic because the ACTH, and this is the other ACTH-dependent phenomenon, is coming from somewhere other than the anterior pituitary, where most ACTH should be coming from. This disease is no longer suppressible, okay? Except when it is suppressible. And I'm sorry, I didn't make that up. It's just the way that it is. And I will walk you through the few exceptions. They're very rare, but they're common enough that as an endocrinologist, we have to be, sort of weary of them. Okay, so what tumors secrete it? Well, again, the vast majority is small cell lung cancer, and then the rest are sort of carcinoids. And then a variety of others. Medullary thyroid cancer, which you're going to learn about, pheochromocytoma you're going to learn about. They're all sort of neural in their origin, secreting forms of hormones that they actually should not be secreting. Whenever a tumor is secreting some type of hormone and you're getting some type of aberrant pathophysiology, we call that a paraneoplastic syndrome. They're fascinating. Unfortunately for the patients, they're associated with a very poor prognosis. When you see ectopic ACTH syndrome, the mortality for a year is exquisitely high. Most patients don't actually live much longer than a year. It's not the Cushing's that actually causes the mortal event. It's their underlying cancer that does. Okay, so those are our two ACTH-dependent forms. What about ACTH-independent? Well, what does that mean? That means that the cortisol production is autonomous and not derived or stimulated by ACTH. Well, how can that happen? So think about an adenoma developing actually in the adrenals. And that generates its own cortisol. That cortisol is going to go back to the hypothalamic and pituitary axis and suppress it. And because there's going to be no detectable ACTH, this is referred to as an ACTH-independent process. Okay? Incidentally, because there is no endogenous ACTH driving this, this too will not be suppressible. And I'll go back to that. But they all look the same. They all look like this in their most classic form. Okay? This is one of those situations where the phenotype is not telling you the problem, as opposed to adrenal insufficiency where the phenotype and the potassium status and hyperpigmentation could actually point you to the direction of where the problem is. So let's go back to our test of adrenal function, and let's remember about circadian rhythm. Okay? Very low levels of cortisol at night, peaks in the early morning, particularly around 8 a.m. Okay, we're not going to try and stimulate cortisol. That's an ACTH or cosentropin stimulation test. We did that for adrenal insufficiency. It has no role here. So how do we approach, and by the way, just to show you now that we're talking about Cushing's and you understand that it's a disease of glucocorticoid excess, just look at the axis here. This is Cushing's disease, so this is ACTH-dependent pituitary Cushing's, and look at the axis. I mean, these levels, there is marked endogenous overproduction of cortisol. And there's a lack of diurnal variation here. There still will be, though, at times where cortisol should peak, a bit of overlap. And that should tell you that a basal cortisol level has no role in testing for cortisol excess. Many people use that test. And when the level comes back as 20, they think, well, it can't be Cushing's, should be higher than that. Not true. A basal morning cortisol test has no role in looking for cortisol excess. So what do we do for cortisol excess? Well, the first question is, does the patient display an excess of cortisol? Do they have features of the syndrome? If they don't, well, then you may not want to go down this road because it's a tricky road. This is another way of saying make sure your pretest probability is pretty high before you start testing somebody. Because if you have somebody and they have depression or obesity or alcoholism, they may have testing that looks like Cushing's, only they don't actually have Cushing's. And you're going to find yourself doing a big workup and lots of imaging tests, and there's no real disease there. Okay? So you have to make sure that someone meets your derived pretest probability before you go down the road of testing for it. If they do, then you're going to want to know what's the source of the cortisol excess. Is this an ACTH-dependent or independent phenomenon? And if it's ACTH-dependent, where is it coming from? So how can we test to see if someone does display an excess of cortisol? Let's think about three things that I mentioned before when I talked about testing for cortisol. One, circadian rhythm. Can we test for a loss of circadian rhythm? Well, you know, we're doing a lot more house calls than we ever did before, so maybe we could just go into someone's house, wait for them to fall asleep, wait for midnight to come, jab them in the arm with a needle, hope it doesn't wake them up and raise their ACTH and cortisol levels, take an evening midnight serum supply of cortisol, and go test it in the lab to see whether or not they're generating cortisol. You can't do that. But you can do that salivary cortisol test that I mentioned. Okay? So that's one way to say, all right, in the evening time, at midnight, should this patient have a detectable level of cortisol? And if your answer is no, but you think the patient may actually, you know, in the physiologic world, the answer should be no, but you think this patient may have Cushing's, well, then you may want to go down the road of doing late-night salivary cortisol. So that's one way you could do it. Another thing you could say is, you know, if I give somebody a drug that turns off their own ACTH production, what level of cortisol should I see in the morning? And that's a suppression test, right? If I gave my wife a milligram of dexamethasone, I don't want to use one of you as a guinea pig here, I'll use my wife. If I gave her a milligram of dexamethasone at midnight and checked her morning 8 a.m. cortisol, it should be very low, less than 2. Why? Well, the dexamethasone is about 20 milligrams of hydrocortisone. She should not be making 20 milligrams of hydrocortisone at midnight. So that hydrocortisone or dexamethasone is going to suppress her own production of CRH and ACTH. And at 8 a.m., there should be no increase in ACTH, and thus no increase in cortisol. Now, in the Cushing's disease states, some are suppressible and some are not suppressible. I will show you an example of how that works. But if you think about it, because their levels of cortisol are so high, some of which are being derived from ACTH, you may not be able to turn off the morning cortisol production of somebody with Cushing. So that could be a good discriminatory test. And the other is just to do a full 24-hour urine collection. And I'll show you why that might be a good test too. So when asking yourself, do they display an excess of cortisol, we have to remember the circadian rhythm. We could test their salivary cortisol at midnight. We can remember that this is an ACTH-driven hormone production, and so we can suppress ACTH and see what happens to morning cortisol, or we could just measure a full 24-hour urine-free cortisol collection. Yeah?
Can dietary habits like excessive eating or fasting really throw off diet?
Yeah, so the question is, can dietary habits throw this off? And the answer is no. Okay. So remember, midnight salivary-free cortisol, because normal individuals have a nadir of cortisol at midnight. So, yeah?
Would you do a midnight plasma cortisol in the hospital?
Yeah, in the hospital, this is a really tough diagnosis to go down that road. Because people are stressed in the hospital, their cortisol levels are usually pretty high. This is an outside world diagnosis. Outside of a hospital world diagnosis. Here's our low-dose dexamethasone suppression test. You can give a milligram of dexamethasone at midnight, and you should not see a detectable level of cortisol in the morning. What level is detectable? Don't worry about it, but I'll tell you what should or shouldn't be normal, but this is very controversial. Remember, though, that ACTH-dependent pituitary Cushing's is a syndrome that has got normal feedback. It's just moved to the right a little bit. So it's somewhat suppressible. In other words, there is a little bit of overlap between what a normal response to dexamethasone at night and what someone with ACTH-dependent pituitary Cushing's may have. Yeah?
Does that low dose only work for ACTH dependence?
I'll show you. I'll show you. So how does this work? So a lot of people get very confused as to what dexamethasone is actually doing. Dexamethasone is not actually working at the level of the adrenal gland. Okay? Dexamethasone is an exogenous steroid. It is a glucocorticoid that is synthesized by a lab. It's a pure glucocorticoid. So it goes in and actually, it induces negative feedback to drive down CRH and ACTH. So if you give somebody a milligram of dexamethasone at midnight, you will drive down CRH and ACTH, and that will drive down cortisol, but there is no direct effect here on the adrenal gland. Okay? So in a normal person in the morning, you should see a very low level or basically undetectable cortisol. Now what happens if we have this process with an ACTH-independent adrenal adenoma, right? So here we have the cortisol that's being autonomously secreted, and endogenous ACTH, well, there is no endogenous ACTH because the cortisol is being secreted autonomously from the adrenal. So we come along and we give a milligram of dexamethasone. Well, what happens? Nothing happens because there's nothing to suppress. There's no effect on the adrenal gland itself, so cortisol levels will be whatever they were in the basal state. Okay? This test is not actually getting at this underlying physiology. This is a screening test to differentiate between normals and those who may have Cushing's. It doesn't actually tell you which form of Cushing's they have. That's a different test. But just remember, when we give dexamethasone, what we're trying to do is suppress endogenous CRH and ACTH and seeing what the morning cortisol may be. So abnormal would be a detectable level, greater than 2 or greater than 5. Don't get hung up on the numbers. And then the last one is, well, what about this 24-hour urine-free cortisol? Well, it's a pretty good test. More than 90% of cortisol is supposed to be bound to CBG, but whenever the levels get in a little bit excess, it actually appears in the urine as free cortisol. There is some overlap between pituitary Cushing's and normal subjects. So again, the test is sort of a screening test. It's not 100% sensitive or specific. It's hard to do a 24-hour urine collection, but it's doable. But because of the overlap, it's not the only test that we use, and we usually ask somebody to repeat it in order to improve the characteristics of the test. Now, depending on what literature you read, excuse me, all of these tests are exquisitely sensitive, right? These are DEX suppression tests here. These are salivary cortisols, midnight, 24-hour urine-free cortisols. The reality is we have to use a group of these tests. So we have to use different ones at different times. And then we sort of think about it physiologically. But for your thinking, I just want you to remember, should salivary cortisol be high at midnight? Should any cortisol be high at midnight? Should it be detectable if we give exogenous glucocorticoids? And should it be detectable in excess of the urine? So let's take a test patient. 36-year-old woman, easy bruising, bleeding, fungal skin infections, recurring, depression, hirsutism, all the stuff that would make you be suspicious, and she's young. So you send off the usual chemistries, lipids, CBC. Now, which of these 3 choices are you going to do? Who wants to do a 24-hour urine cortisol times 2, a milligram DEX suppression test, and a late-night salivary cortisol times 3? Hands? One hand. Brave. Who wants to do a CT of the adrenals, MRI of the pituitary, and just a straight-up morning cortisol? And who wants to do an ACTH morning cortisol, and then we'll do some imaging tests based on what those 2 come back as? All right, let's go back to the first one. Who wants to do a 24-hour urine-free cortisol, milligram dexamethasone suppression test, and a late-night salivary cortisol? Yes, you are correct. By the way, a hallmark of endocrinology is you never image until you've made a biochemical diagnosis. So should cortisol be high in the saliva? No, but it was 3 times what we'd expect it to be. Should it be detectable if we're giving a milligram of dexamethasone? No, but the morning cortisol was 25. Okay? And a normal person, it should be less than 2. And should it be detectable in the urine? In excess, no, but it's 4-fold above. All of these are sort of floridly high levels of cortisol production. Now let's find the source. Okay? So now we can send off an ACTH level, because we want to know, is this ACTH dependent or independent? That's the next part of our tree. Here is ACTH independent adrenal processes, completely undetectable ACTH levels. Here is pituitary ACTH Cushing's. Here's normal. And here's ectopic ACTH. Well, there's a big problem here, right? There's a lot of overlap here. About 30% overlap between Cushing's and ectopic ACTH. So that test can't differentiate between the 2 of them. But once it's undetectable, you're going to go look right at the adrenal glands. You don't really need to do much else. You've proven they have a cortisol excess, and it's not ACTH dependent. Okay? And that brings you down this tree here. But if ACTH is detectable, well, is there some way we can differentiate between this and this? Well, remember, this one here is suppressible if you give enough steroid, because the axis is right-shifted. If you can give enough steroids to suppress CRH, you'll turn off some ACTH, and you may see a response in morning cortisol. This disease here, ectopic ACTH, is not suppressible, because it's a lung or other cancer that's just autonomously making ACTH. So how does that work? Okay. Slowly, slowly. instead of 1 milligram, we give 8 milligrams. What's 8 milligrams? That's about 160 milligrams of hydrocortisone, right at night, okay? Remember, in a replacement patient, you're giving them 10 milligrams. This is a whopping dose. And that 8 milligrams at midnight is going to be enough to turn off a little bit of CRH and drive down ACTH production so that your morning cortisol after the 8 milligrams of dexamethasone will probably be more than 50% reduced. This is the somewhat suppressibility that I talked about before. Compare that to an ACTH-dependent ectopic ACTH syndrome. Here you can give 8 milligrams of dexamethasone. This is autonomously secreted ACTH that has no physiologic regulation. And in the morning, the cortisol levels will be less than 50% reduced. This is a pretty good test. It's not foolproof. It's not foolproof mostly because of this. Okay, so most of us do this test. We don't rely on it anymore to find out exactly where the source of ACTH is. It helps us because we really want to make sure before we image the pituitary gland that we have good evidence that there's ACTH production is coming from the pituitary. And that high-dose dexamethasone suppression test assists us with that. But it doesn't absolutely make the diagnosis. Okay? And the last thing you want to do is go in and operate on someone's pituitary gland only to find out that the problem was a tumor in the lung that suppresses with high doses of dexamethasone. So how do we differentiate that two? Well, we actually stick cannula up into the petrosal sinuses which drain the pituitary, and we sample for ACTH. Now, yes, we do an MRI of the pituitary first. And if there's an adenoma there are some people who would say, well, if they're high-dose suppressors and you have an adenoma, go into the pituitary. But nobody really does that anymore. We all basically rely on this testing. Here's the cannula here, draining the venous circulation of the pituitary. You give CRH. Remember, pituitary ACTH-driven Cushing's disease still has some physiologic regulation. So you give CRH and you see a rise in ACTH that's coming centrally. You compare that to the ACTH you see peripherally. If this person has ectopic ACTH, then giving CRH isn't going to do anything to drive up the ACTH levels. And their central to peripheral levels are going to be pretty much equivalent. On the other hand, if they have endogenous ACTH production from a pituitary tumor, you give CRH, it will drive up their central ACTH. You will measure that here, and there will be a central to peripheral excess of around 3 to 1. Don't worry about the numbers. It's the physiology that I care about. So we can sample the responsiveness of the pituitary to CRH to see whether or not someone's ACTH-dependent Cushing's is centrally mediated and Cushing's disease or peripheral. So we're going to try and find the source of the steroid excess. Well, ACTH was high. We gave 8 milligrams of dexamethasone. There was a more than 50% reduction in the morning cortisol. That makes us think of a pituitary process. We did an MRI, but we don't see anything. So we did petrosal sinus sampling, and it showed a marked central to peripheral step up in the level of ACTH that was measured. And so now we have a diagnosis. This is ACTH-dependent pituitary Cushing's, aka Cushing's disease. Everybody comfy with that? There'll be some good exercises in the small group. Okay, so how do we treat it? Well, surgery on the pituitary. Okay, this is not one of the pituitary tumors that we give drugs to first. It's surgery first. The ectopic ACTH syndrome, you have to treat the underlying tumor, and for the ACTH-independent adrenal problem, you have to basically surgically remove the adrenal that has the adenoma or carcinoma in it. Because of such high levels of steroids, all of these patients, when you treat their tumor, are going to be adrenally insufficient the next day because their systems have basically been suppressed. So you have to give them some supplemental steroids. And then a couple weeks later, you remove all the supplemental steroids and you retest them with free cortisols and a milligram of dexamethasone, and you see whether or not their cortisol levels are still in excess. And that's how you monitor for recurrence, and that's what we do to check for a cure. Okay? Any questions on that before I go to congenital adrenal hyperplasia? Mm.
Why doesn't CRH in ectopic ACTH? Why doesn't CRH another source of ACTH because it's too downregulated cortisol?
No, it's because the question is, why doesn't CRH play a role in ectopic ACTH and changing the central to peripheral levels? Is that what you're saying? Yeah, so the answer is that in the tumors of the lung or ectopic ACTH syndrome, that ACTH is being autonomously secreted irrespective. There is no negative feedback loop for that.
Right, okay. But if you are stimulating like the primary source of ACTH rather than the ectopic source, why wouldn't CRH?
Oh, so the question is, centrally speaking, why wouldn't you still see a step up, even if, because you're giving CRH right to the anterior pituitary, why would you not see a step up in ACTH production? So who can answer that question for your colleague? Yeah?
Is it just because the exogenous levels are so much higher?
Yeah, I mean, that hypothalamic pituitary system is totally shut down. Okay, good. So we're going to talk about congenital adrenal hyperplasia. This is a series of autosomal recessive genetic diseases with very diverse phenotypes. As I mentioned, every single one of these enzymes has a form of congenital adrenal hyperplasia associated with it, actually, except this one. It is an enzymatic defect in the normal production of cortisol. This is the critical one here, okay? That cortisol is not being made. And that leads to a lack of negative feedback with a marked increase in ACTH. The high levels of ACTH actually go down to the adrenals and stimulate and hypertrophy them. And that's why it's called congenital adrenal hyperplasia. That's what the glands looked like on autopsy when they were taken out. Now, the ACTH is driving forward the process, but the defect is in the adrenal gland, in one of these myriad of enzymes. The rise in ACTH comes because cortisol is either not made at all, aka primary adrenal insufficiency, or it's made but not enough of it is made so that you still see some rise in ACTH. And that variability comes because the defect in the enzyme is variable based on where the mutation is that derive the actual disease state. So some diseases have partial defects. Some of them are classic. They just induce adrenal insufficiency from day one of life. Others may not present until 20, 30 years of age. Those we call late onset. Okay? And those late onset ones, they may not even have adrenal insufficiency. Because you can imagine, you can't really live 25 years without a functional adrenal gland. And that's because there's a partial defect, so there's just enough glucocorticoid to be made and keep somebody out of acute adrenal crisis. But the enzyme's still dysfunctional, and so other things are happening. Now, I mentioned that cortisol doesn't get made, there's negative feedback, and ACTH goes up. Well, ACTH drives forward the production of all of these hormones, not this one, and these, and these. If you can't make the end product, you will get a rise in precursor hormones. And funnily enough, that's how we make the diagnosis and figure out where the defect is, by looking at a rise in precursor hormones. Sometimes those precursor hormones are completely inert. Sometimes those precursor hormones are going to get shunted to make something they shouldn't be making because there's so much ACTH being generated by the lack of cortisol. And sometimes those precursors are actually going to be hormones themselves. And that leads to its own pathophysiology. So let's look at the most common one, which is 21-hydroxylase deficiency. So 21-hydroxylase in the glomerulosa takes progesterone to deoxycorticosterone. And in the fasciculata, it takes 17-OH progesterone to 11-deoxycortisol. Okay? Now there's variable forms of the deficits, as I mentioned. And depending on when the deficit starts, you're going to get a different phenotype. Now, if this is this is autosomal recessive, so if this is happening to a baby that's developing in utero, and ACTH levels are very high, but they can't make cortisol and they can't make mineralocorticoids, and everything gets shunted to adrenal androgens, which are ACTH sensitive. If they make a lot of adrenal androgens, well, if in a developing female, that's going to cause ambiguous genitalia. So clitoromegaly and labioscrotal fusion. If that is seen on a newborn, they call pediatric endocrine. It's one of their emergencies. Okay? They don't call me. I'm an adult endocrinologist. They call Dr. Mazumdar from Growth and Development. Okay, so ambiguous genitalia in a female. Now, in a male, nothing. A rise in adrenal androgens in the developing male causes no phenotype. Both the male and the female who are suffering from an enzymatic defect such that ACTH is shunting adrenal production of hormones to adrenal androgens will develop advanced growth. Remember, the sex steroids are what sort of induces part of linear growth. So at a younger age, they're going to be taller, but the sex steroids also shut off growth early. So if it is not picked up on, the epiphyseal plates will close, and they will develop short stature for the duration of their life. Okay? So that high level of androgens will do this to both males and females. And remember, Dr. Mazumdar said most people don't bring in their kids who are excessively tall, so it can be missed. In adults, no phenotype in the males. Hirsutism, change in periods, infertility can be what females suffer from this condition. So remember, enzymatic defect, no production of the end hormones, and a physiologic upregulation of ACTH in response to that, which then takes the precursors, increases them in their concentration, and also shunts the pathway down an aberrant arm. Clear-ish? Okay. This is just an example of ambiguous genitalia. There are 3 presentations of this. The wording is a little bit confusing, but there is classic, which means it happens immediately. Sodium wasters, virilized females, acute adrenal insufficiency. That's what I'm writing here. So classic salt wasting variant. This is a full enzymatic defect. There is no cortisol production. Okay, within a few days of life, that baby is adrenally insufficient. It is a form of primary adrenal insufficiency. There is a lack of aldosterone or mineralocorticoid production. Okay? Because even though this is angiotensin II mediated, you still need to go down this pathway, and it can't. Okay? So there is this shunting to adrenal androgens. So acute AI at birth, salt wasting with hyponatremia, hyperkalemia, acidosis, vascular collapse, and ambiguous genitalia in females is the presentation for classic salt wasters. I read the other day they called them salt losers at one point. That is horrible. Call somebody a loser. Not even their fault, it's their genes. It's terrible. So we will call them salt wasters. Yeah?
Do they test for these enzymes at birth?
Don't jump ahead of me. But yes, they do. So the other variant is classic simple virilizers. Low but sufficient production of cortisol to prevent the acute adrenal insufficiency. Okay? You can imagine the mutation doesn't cause as severe a defect in the enzyme capability. Low but sufficient production of aldosterone to prevent salt wasting. But there is still a rise in ACTH, still a buildup of precursors, and still a shunting, so that there is a virilization that occurs. It's less severe than the classic salt wasting form, but it's still there and progressive if left untreated. With the same problems, it will cause ambiguous genitalia in females, no phenotype in males. As the children develop, it will cause early advanced height with premature closure of the epiphyseal plates and short stature. Okay, and because of the androgens, it will also develop precocious puberty, so they'll go into puberty early. Then there is the late onset phenotype. Now these are mild enzymatic defects, and there are a lot of them. Okay? We don't actually, well, I don't want to jump ahead. I tried to answer your question, but I don't want to jump ahead. This is the most common phenotype. All right? There's an ethnic proclivity for it, as you see there. Cortisol's fine. Aldosterone, fine. But there are still excess adrenal androgens only this sort of becomes a problem in late adolescence and early adulthood. So like in your 30s or 40s. Normal genitalia at birth. It is a cause of secondary amenorrhea. There is acne and hirsutism and premature puberty from the excess androgens. Otherwise, it's relatively asymptomatic. They can make cortisol to keep themselves out of crisis, but they are not making enough that there's still a lack of cortisol feedback, and so there is still an increase in ACTH, and there is still the increase of precursors, and there is still a phenotype. It just happens much later in life, and it's not associated with severe life-threatening problems, but it is associated with problems. So to answer your question, how do we make the diagnosis? Well, heel stick testing in newborns looks for 17-OH progesterone, that one right there. This is how we make the diagnosis. There's cutoff points for how high we would expect it to be. If it's pretty high but not quite so high, you can give a big dose of ACTH and see if you could push it to go up, because the normal response wouldn't be to generate precursors. The normal response to a big dose of ACTH would be to make cortisol. Okay, so if you find that 17-OH progesterone levels go up, that tells you that the defect is here at 21-hydroxylase. This is the one they test for in newborns, not the others. Because this one's common, the others are very rare. What's the therapy? Well, actually, the therapy is directed at the hypothalamus and the anterior pituitary. The problem here is the very high levels of ACTH that need to be turned off. And so the treatment is, of course, if they're adrenally insufficient, they're going to need glucocorticoids. If they're aldosterone deficient, they're going to need mineralocorticoids. But even in the late onset forms, you need to give a dose of steroids to suppress and turn down that ACTH production. And if you can, you will drive down the excess precursors and drive down the shunt to adrenal androgens. Very hard to balance that out in children because glucocorticoids can cause basically Cushing's, and it can cause growth retardation. Okay, so it's a very delicate balance in kids. Not such a problem in adults, but of course you want to use the lowest possible dose, as I told you, except this is lifelong therapy. This is not something you're going to be able to turn off. So prenatal diagnosis, affected parents, it's autosomal recessive. If they have a developing female, then there's a 1/4 chance that that developing female may be virilizing actually during their development. And that has led to, well, how early can we make the diagnosis of the sex, the gender of the developing baby? Because if it's a male, there's no phenotype there, and when they present, then you can do other testing to figure out if they have high 17-OHP levels. For a female, though, developing female, if you don't turn off the ACTH levels during development, they will have virilization. And so there's a thought that you can give dexamethasone therapy to the mom early on in pregnancy to prevent the virilization. All right, it's pretty controversial. We'll talk a little bit about it in the sessions today. So I think that's about it. I'm just going to show you this as sort of a lead-in to Wednesday, which is the next time I'll give you guys a talk, that all of these are associated with independent phenomenon. Save this one. I will tell you the ones that I think are of relevance to you guys for the course and the most common ones. Clearly now you need to know what happens when 21-hydroxylase doesn't work. I'm also going to ask you to be responsible for 11-beta-hydroxylase and 17-alpha-hydroxylase, and we'll go over those on Wednesday. All right, so have fun in your small groups, and I'm around if you have any questions. Welcome back.